96. We haven't done body fluids, so your own urine, testing your own blood, live animal kind of stuff. And I've been quietly working behind the scenes, and we've been able to do that. And so for lab today, there's two aspects of lab. One is the physio act that you guys started with in Bio 430 with the muscle and the nerve computer simulation. Part of the heart simulation is using a frog heart. We don't have the entire apparatus, but as far as the pressure transducer and seeing the change in force of contraction. But we do have live frogs and two drugs, epinephrine and acetylcholine, that I'll be using as a demonstration for the effect of those drugs on heart rate. There's other drugs and ions that you'll be using as a computer simulation, right? So I'll be, I don't know if you know the term PIP, but pipping is a way of destroying the brain and spinal cord by passing a needle probe up through the foramen magnum and down into the spinal cord. It takes about 2 seconds. And then the animal's heart and lungs are still working, but the animal is brain dead and spinal cord dead, so they don't feel any pain. I'm saying that I will be pipping the frogs in the cadaver room. If you're interested in watching that, you're welcome to. Because this is a live animal type of experiment, I don't want to force anybody to do that has, believes that they don't want to. Your fog experiment on the PhysioX, the simulated one, is very similar with additional stuff and actually more. They have the transducer for the pressure, so it's totally up to you if you want to observe that. So what I will be doing is pipping it in the cadaver room, and then I will have it pinned to a board and open up the chest wall, and you'll be able to visualize the heart inside the pericardial cavity. And then we have the drugs that will kind of drip onto that, and the acetylcholine and norepinephrine drugs, which are the parasympathetic and sympathetic effect. Okay? So hopefully, it's not a complicated activity, so hopefully it'll work well. They're large frogs, and so the heart size and stuff should be something that, I know sometimes the computer stuff gets a little hard to keep focused on and so on. So I wanted to try this, kind of introduce this kind of stuff back gradually, and then hopefully we can get the transducers and everything for it. So I want to go back and review cardiac cycle with you and some of the sequences of valve changes. Why is this not showing? So hopefully you had an opportunity
what you do differently. Don't tell me this.
Validated samples and wrote notes on concepts I wasn't keeping straight in my head. And then I did it again. And again. And again. It's called I Learned. Not the night before.
I'll have you know, I did not study the night before. I studied the night,
The night before, but not the night before.
but the night before.
Did you study that one time?
I studied a couple times.
Multiply that by 10. Reach to 5.
See, studying English, everyone's good. Studying math and science all day.
That's what I think too. I did it.
All right, so remember on this screen, you can see pressure relationships, ventricular volume, and the ECG. All right. So let's go through this together. And we'll put up our ECG here first. Okay, so P wave, Q are S wave and P wave, and then P wave again. So what does the P wave represent? What causes the P wave to appear on an ECG? Okay, so the wave of current passing through the atria. Excellent. That's instigated by the firing of the SA node, but when the current travels through SA node, AV node, through bundle branches, bundle, AV bundle to bundle branches, we don't see that showing up on the ECG. Okay? So whenever that type of the pacemaker potential is occurring or the traveling through the conductive cells, we see a flat line as far as the appearance on the ECG. So this flat line between the T wave and the P wave represents a period of time when both the atria and the ventricles are at rest. Anybody know what we call that rest period? Well, the either ventricular contraction, heart contraction or relaxation, we use the terms systole for work contraction and diastole for relaxation. So during this interval, both the heart, both the atria and the ventricle are relaxed. So the heart is in diastole. And the AV valves are open. Semilunar valves are closed. And this is known as ventricular filling. All right, so we're just ending ventricular filling at this point. So if we look at aortic pressure is going to be dropping. What causes aortic pressure to rise? The stroke volume, the contraction of the ventricle, and that one stroke pushing approximately 70 mils of blood into the aorta. That's going to cause the vessel walls to stretch, and that push of blood is going to cause the blood in front of that to move through and the blood in front of that to move through. And as the heart relaxes, the aorta elastic fibers recoil, and that continues to create a force. If they just sat open like that, there wouldn't be any continued force. So that continues to create a force that pushes the blood through, but the pressure is dropping as that blood continues to move through. So we see a continued dropping of aortic pressure. Right? Notice that the highest pressure, unless the ventricles are ejecting blood, is going to be the aorta. The lowest pressure is going to be the atria as far as an average is concerned. Ventricular pressure will be lower than atrial pressure at a time, but as far as what we commonly find down at the bottom, it's going to be atrial pressure, and in between, ventricular pressure rises and falls. Okay. So while the heart is at rest, blood is flowing into the atria, but the AV valves are open. And so we don't see an increase or a decrease in atrial pressure, because the blood is just flowing into the atria. Then we see the beginning of atrial depolarization. All right, what causes this? The autorhythmic cells depolarizing and reaching their action potential, the pacemaker potential. All right, so the atrial cells start to depolarize, and that causes an increase in atrial pressure. Because even though the AV valves are open, we have a contraction and a squeezing of the atria. So in line with P wave, we see this increase in atrial pressure because we have the atria contract. Ventricular pressure is lower than atrial pressure at this point. Even if I didn't show you that on the diagram, how would you know that ventricular pressure is lower than atrial pressure based on what we looked at over here? We're at this point over on this side.
The AV valves are open?
Because the AV valves are open, all right? So it goes both ways. The ventricular pressure is lower than atrial pressure because we know that the AV valves are open. Or because ventricular pressure is lower than atrial pressure, that's going to force the AV valves open. So the higher atrial pressure pushes blood through the atrioventricular valves, and that's what is keeping them open, is that higher pressure in the atria versus lower pressure in the ventricles, and that's what you see right here. This relationship of atrial pressure to ventricular pressure is what is maintaining the opening of the atrioventricular valve. So now atrial pressure starts to drop as the atrial depolarization is finishing. And during this period of time, we see, and I've got a prolonged space here, longer than what you see over on the screen, but we see a rise in ventricular pressure. Okay. And then the ventricular pressure starts to increase as the ventricles depolarize. And the ventricles start contraction from their apex. So as that starts to occur, we see a rise in ventricular pressure. That rise in ventricular pressure then causes the ventricular pressure to be greater than atrial pressure. We see a little bit of a blur just because of the disturbance in the blood flow as the valves close. And atrial pressure is going to fall for a little bit, and then it's going to start to gradually rise. Because blood's still coming into the atria, but not going anywhere. So it's going to cause the atrial walls to start to stretch out, because blood is continuing to come into both of the atria. All right. During this entire time, the aortic pressure is falling. And notice there's a very rapid rise as soon as this change occurs. There's a very rapid rise in pressure. As soon as ventricular pressure becomes greater than atrial pressure, what's that going to do to the atrioventricular valves? They're going to close. So at this event right here, the AV valve will close. Now we're just looking at the aortic, but I'm making it plural because they both close at the same time. Okay, our pressure levels would be different. The ventricle's not going to pump with so much pressure, but the valves are going to close at the same time. What is the position of our semilunar valves? Are they open or closed? All you have to do is look at the picture. All right, even if you can't remember what's happening in the heart, all you have to do is look at the picture. What is the semilunar valves are found between aorta or pulmonary trunk and ventricles. That's where the pressure relationship occurs. So If aortic pressure is greater than ventricular pressure, there's going to be a slight backflow of blood and filling up the semilunar valves, and that causes them to close. If ventricular pressure is greater than aortic pressure, it's going to push up and open up those cusps and cause the semilunar valves to open. So all you have to do is look at the image here. Aortic pressure is higher than ventricular pressure. So that means the flow is going to go towards the ventricles. It's going to fill up those three little cusps of the semilunar valves and keep them closed. So at this time, the AV valves are closed. The semilunar valves are closed the entire time the aortic pressure is greater than ventricular pressure. So both aortic valve and AV valves are closed. All right, so at this time, up here, aortic valve, semilunar valve, I'll just put SL. Are already closed. Now, with our rapid rise in ventricular pressure, it becomes greater than aortic pressure, and that's what opens the semilunar valves. Okay? So at this time, semilunar valves open because ventricular pressure is pushing them open. And you can tell that they're open because ventricular pressure is greater than aortic pressure. So you can see that on the image. Remember I said you would have this on the exam. I won't have it labeled. One of the questions, some of the questions will be, what's happening here? What's happening here? And I want you to be able to tell me the AV valves are opening or closing, semilunar valves are opening and closing. And I won't tell you what the pressures are, but by their relationships you should be able to figure that out. But you'll have the picture. Okay? And that has all the information on it that you need. Now, there is a short period of time from when the AV valves close until the semilunar valves open, when both valve sets are closed. Blood is not coming into the ventricles and blood is not going out. That's why we have such a rapid pressure change, because the ventricle space continues to get smaller, but we're not losing any volume. All right, so what happens to gas pressure? You decrease the space, pressure goes up. All right, so we see a similar effect here. So this is identified as isovolumetric, meaning no change in volume, and it's occurring during contraction. So it's the period of isovolumetric contraction. And it's when both sets of valves are closed. Now I'm not telling you anything new, okay? We're just putting all the cycling and valves opening and closing and stuff together into a sequence, but none of this should be new information. Once the semilunar valves are open, we have blood going into the aorta, and blood going into the pulmonary trunk as well. So we see this rise during ventricular contraction. Remember, QRS is representing the depolarization of the ventricles. So the ventricles are contracting. So during this time of ventricular contraction that's greater than aortic pressure, we have blood leaving the ventricles. So aortic pressure very closely follows ventricular pressure, but ventricular pressure is still greater. As long as ventricular pressure is greater, blood is leaving the ventricles. And so this is known as ventricular ejection. Now the ventricular contractile cells undergo repolarization as potassium ions are leaving and calcium ions are being pumped back into the sarcoplasmic reticulum. Less actin and myosin heads are attaching, and so the ventricles start to relax. And we start to see a decrease in pressure as we move through the T wave, which is ventricular repolarization. This represents what's happening in the ventricles is relaxation of the ventricles. Okay? So now ventricular pressure starts to drop. And as it drops, it passes a point where it becomes less than aortic pressure. And at this point, semilunar valve open.
They're already open.
Sorry, thank you. Just checking if you're awake. Semilunar valves close. And again, that closing creates a little bump in pressure, the turbulence. And this is known as a dicrotic notch. First new piece of information. And then we can continue to see aortic pressure dropping until the next ventricular contraction. So at this point in time, semilunar valves closed. Our atrioventricular valves are still closed, so no more blood is coming into the ventricles yet. And so we see a rapid drop in ventricular pressure because the ventricles are relaxing, and yet we're not gaining any more blood. We're not losing any more blood, but because the ventricles are relaxing, we see this drop in pressure. Atrial pressure, in the meantime, remember, has continued to rise because blood is continuing to go into the atria. And so we see ventricular pressure falling below atrial pressure. And the AV valves open. So we have another period of no volume change. From the time the semilunar valves close until the atrioventricular valves open is another isovolumetric period, but this time it's when the ventricles are relaxing. So this is known as isovolumetric relaxation. There's a rapid drop, slight but rapid drop in atrial pressure as all the blood that's been building up in the atria flows into the ventricles. And then it starts to kind of level out again. And we repeat the whole process as we go through ventricular filling. And that's the cardiac cycle. Okay? Yes?
Okay, so the aortic pressure is increasing to after, like following the ventricular?
Right, the aortic
because it's
pressure is because, think of a balloon that you're blowing air into. All right? The balloon is filling out and has pressure as you push more air into it. So as we pump blood into the aorta, it's pushing that fluid of the blood against the aortic walls.
Okay.
So that's stretching out and pushing against the walls and creating pressure against the aortic walls. So when we look at the range here, this is essentially what diastolic and systolic pressure is when we measure blood pressure. So when the heart is at rest, the aorta has its lowest pressure, and that's going to move on down the blood vessels. When the heart is filling at its highest point, that's your systolic pressure. We don't measure it in the heart, we measure it across systemic vessels, but that's why it's there and where it comes from. Now, yeah.
Okay, so as soon as the semilunar valves close, is the pressure in the ventricle is lower, right? 'Cause
That's
then
why the
that's-
semilunar valves
that's-
close.
Okay, that's why they close.
So the pressure is always the Y of the valve
And
change.
they stop contracting, right? So that's why it's repolarizing.
It's relaxing.
Or relaxing.
So yeah, it's fewer and fewer fibers are in a contractile state.
Mm.
And even within the fibers, fewer and fewer actin and myosin filaments are creating tension. So our ventricular pressure drops until it's back down to the complete diastole of complete rest, when they're not contracting. Okay. Now, leave that image up on the board, and I want to create some relationship pressures here. I don't know if any of you had a chance to work on the exercise activity, but there were some matching sequence kind of components where we look at relationship pressures. And so if I said that atrial pressure is greater than aortic, well, let's rephrase it this way, I don't want to start off with that one. Aortic pressure is greater than ventricular pressure. It would be the left ventricle, obviously, and that's greater than atrial pressure. Okay, try just thinking about that without looking at the image. What valves would be open and what valves would be closed?
They're both closed, aren't they?
So remember, aortic to ventricular is going to be our semilunar pressure valve, and ventricular to atrial is going to be our atrioventricular valve sequence. So if aortic pressure is greater than ventricular, semilunars will be closed, and if ventricular is greater than atrial pressure, AV valves will be closed. Either they just are closing or they've been closed for a while. All right, so what do we call this time point in our cycle when both valves are closed?
Isovolumetric.
Isovolumetric. Now from this, I can't tell whether it's contraction or relaxation. There's nothing in here that tells me that. All I know is that I'm in the isovolumetric period, one of them. Either contraction or relaxation. Okay? So between these two sets of dotted lines, that's the pressure relationship that I'm going to see. So you'll have questions where I'll give you multiple choice of their pressure relationships. This is on the worksheet. So during ventricular filling, which of the following represents the pressure relationship? During ventricular ejection, during isovolumetric, when the semilunar valves close, when the atrioventricular valves open. All right? So you can figure those out from the picture, or you can figure them out looking at the relationship. So let me change. I'm going to just keep erasing and putting back up, so I don't want to do that unless you guys are keeping up. You guys okay with that? All right. So now let's look at ventricular pressure is greater than atrial pressure is greater than aortic pressure. So if ventricular pressure is greater than atrial pressure, we're looking at our AV valves. AV valves would be, AV valves are directed this direction, so if the lower pressure is greater, it's going to close the AV valves. So AV valves are closed or have just closed. If ventricular pressure is greater than aortic pressure,
Semilunar valves are open.
semilunar valves would be open. What's wrong with this? Anybody see anything wrong with that?
Should ventricular, aorta, atrial?
Do we ever have atrial pressure greater than aortic pressure?
No.
What would be the problem if we did?
You would have nothing.
You would have no pressure in the aortic system and no blood flowing returning to the heart. Atrial pressure has to always be lower than aortic pressure, because blood flows from high pressure to low pressure. If atrial pressure is greater than aortic pressure, it's going to be flowing out of the atrium, back to the lungs, and back to the body. So this is a condition incompatible with life. Never ever choose an answer where atrial pressure is greater than aortic pressure. Yes, it fits these two situations for our valves because of the ventricles, but this relationship is never going to exist in the living person. Does that make sense? Because our aortic pressure would be way down here, meaning there's no ventricular pumping, or for some reason our atrial pressure would be way up here, and there would be no blood flow. Or if there was, it would be backwards. Okay? So that doesn't exist. anytime, no matter what the sequence, if atrial is in front of aortic. So let's put it in this direction then. Ventricular pressure is greater than aortic pressure, which is greater than atrial. That works. So ventricular pressure is greater than aortic. We're talking about which valve set? Semilunars. Semilunar valves would be open. If ventricular pressure is greater than atrial pressure, AV valves would be
Closed.
closed. Okay, so what's the situation when this happens?
Ventricular ejection.
Ventricular ejection. All right, AV valves are closed, semilunar valves are open. Blood is leaving the ventricles and moving into the aorta and pulmonary artery. So there's really only a minimum amount of pressure relationships, all right? There's a pressure relationship for ventricular ejection. There's a pressure relationship for isovolumetric either contraction or relaxation. What would be the pressure relationship for ventricular filling?
Atrial pressure would be higher than ventricular pressure.
All right, so atrial pressure would be higher than ventricular. That would mean that our AV valves are open. And what position are the semilunar valves during ventricular filling?
Closed.
They're closed. So to keep them closed, aortic pressure is going to be higher than everything, all right? We know it already has to be higher than atrial. And it has to be higher than ventricular to keep the semilunar valves closed. So now semilunar valves are closed. And we have ventricular filling. Okay. So practice looking at these different points and figuring out the pressure relationships, or looking at the pressure relationships and determining which is higher, which is lower, which valves you're looking at, and whether they're open or closed. All right, it sounds complicated, but all the information is right there in front of you. So don't be intimidated by that aspect, and if it seems a little confusing, I have that video that Thursday night with the link to that component. Now, before we leave this, I want to point out there's a couple of new terms here that we need to discuss when we talk about cardiac output. And that's the bottom diagram, bottom line on the diagram, is not a pressure change, but a volume change, specifically the ventricle. So you'll notice what's happening to ventricular volume. Let's see if I can, here's a purple color. So it's not at the bottom of the screen, and you guys can see better. I'm going to put it I'm going to erase the ECG and put it at the top. You guys can follow along with that. So while we are in ventricular filling, which is what happens until the AV valves close, because obviously once the AV valves are closed, we can't fill the ventricles anymore, right? So while we're in ventricular filling, we see an increase in ventricular volume. So there's going to be an increase in volume. When the atrial contracts, there's a slight little bump, okay? Just because there's that last minute squeeze of blood as the atria contracts in the P wave. And then the AV valves close. Semilunar valves are already closed, right? So we have a flat period. Well, let me at least get over here to the point where it matches up. This is a little drawn up, a little bit too much here. So during the isovolumetric contraction, there is no change in our volume, the ventricular volume, and that's represented by this straight flat line there. Doesn't go up, doesn't go down. And that's the maximum volume of blood in the ventricles. Does that make sense? Because blood's continuing all the time, and then we close off the doors, no more blood's going to come in. No blood is leaving, so that's our maximum volume. And that's the end of ventricular filling, or diastole. And so this is known as end diastolic volume. It's the highest amount, the greatest amount of blood that's found in the ventricles. It seems a little weird that it's at the end of rest, but yet it makes sense, because that's when the heart is filling with blood, is during rest. Okay? Then the atrial ventricular valves remain closed while the semilunar valves open, and we have ventricular ejection. So while we have ventricular ejection, ventricular volume is decreasing and continues to decrease until the semilunar valves close. And then we have another straight line. This is the lowest volume of blood in the heart. It's not completely empty. It's really, in normal heart cardiac cycle, we've really only pumped out slightly more than half. So we've gone from 135 mils average to about 65. And this is known as end systolic volume, the end of systole, the end of contraction. Okay. So the difference between the two, 135 minus 65, the difference between this and this is the volume of blood that was pumped out by the ventricle. Does that make sense? So that volume is called stroke volume. So end diastolic volume minus end systolic volume is equal to stroke volume. And stroke volume is defined as the volume of blood in milliliters ejected or pumped, whatever term you want to use, by one ventricle in one contraction or one stroke. Okay, so the volume of one ventricular contraction, just one, not both. They should be equal though, right? Mm-hmm. Right ventricle and left ventricle should pump the same. So on average, that equals 70 mils. Pumped by the left ventricle, 70 mils pumped by the right ventricle. Okay, any questions on that? It looks complicated with all those lines and colors on the screen, but if you take it slow, it's logical. Right. It's, think about where the, as you push on a door, you're pushing the door open or pushing the door closed, and that's what's happening to the valves. Yes?
So as the volume is increasing, and then the AV valves close, is the ventricles all relaxed during that period, and then as soon as the AV valve closes, then it starts to contract?
The AV valve is closed because it's contracting.
Oh, because it's
So remember what contraction does is it decreases the volume, and that increase that the volume that decreases the space that the blood is in, and that increases the pressure. So if I have a plastic bag filled with fluid and I squeeze that bag, all right, there's going to be more force on the outside of the bag pushing in on the blood. So that's what causes the increase in pressure here, is because the ventricles are starting to contract. And that increase in pressure then is what closes the AV valves. So this first rise in pressure is because the ventricles are starting to contract. They continue to contract, and the reason our pressure spikes so rapidly is because there's no place for the blood to go. until
they
the,
open.
but you'll notice as soon as those valves open, the gradient, the pressure doesn't change quite as rapidly. It's still going up, but it starts to level off because blood is moving out of the ventricles, and so we don't see quite as sharp an increase. Now, you've probably heard of heart sounds. So there's a disturbance in the blood when these valves close, and when you listen, and you can do this when we do the blood pressure exercise activity next week, when the heart valves close, they create a sound, all right? And so when you listen with the stethoscope, in fact, when we do ECGs, you guys can listen at the same time. This is called the lub-dup sound. And this diagram is showing, remember the heart is slightly off-centered. So these are the two semilunar valves and the atrioventricular valves. So here's the pulmonary trunk and the atrioventricular valves. And so they're best heard not right over the heart, but between the ribs on either side of the sternum, because many of these valves are right underneath the sternum, which is going to muffle some of that sound, all right? So the best sounds for the aortic and pulmonary valve are heard in the space between the second and third intercostal ribs. Aortic on the right side and pulmonary on the left. And then the atrioventricular valves are best heard down below, so basically down here. So up here for the semilunar valves, down here for the atrioventricular valves, right? And then we switch, because remember these vessels are crossing over. So left and right-sided valves here, right and left-sided valves, the atrioventricular, because of the space. So you hear a lub-dup. Which valves close first? Atrioventricular. So they have a lower, deeper sound. I say lub, sometimes we'll put a lump, but it's really a lower lub, lub, dup, a sharper, higher sound for the semilunar valves. Okay? So in your heart, in your cycle, remember the rest period is a little bit longer than contractile period. So it's not a lub, dup, lub, dup. It's a lub, dup, then rest. Lub, dup, then rest. Okay, so those two sounds come pretty close together for atrioventricular and then semilunar valve closures. You can listen to the heart sounds with that. And so, remember, with cardiac cycle, we don't have one chamber closing and then another chamber closing in sequence. Both atria and ventricles are relaxed at the same time. We have our P wave instigated by the firing of the SA node pacemaker potentials that spread quickly both through the right atria and the left atria. They contract, then the current passes down through our interventricular bundle and up through the conduction myofibers, and the ventricles both contract at the same time. So it's this and then relaxation, then this and relaxation, okay, in sequence. So if you're going through one drop of blood or one red blood cell pathway, yes, you're going to go from one chamber through the valves to the next chamber, through the valves, and so on. But if you're looking at the heart's activity, both atria and then both ventricles and then relaxation. Both atria and both ventricles and relaxation. So that brings us to cardiac output. We're going to look at cardiac output again when we do blood pressure, because obviously the amount of blood pushed into the arterial system is going to affect blood pressure, blood volume, and so on. And so may I raise the board? So cardiac output is a formula that involves stroke volume and heart rate.
Beats per minute, milliliters,
So you're going to get mils per minute
mil per minute.
as your final volume.
That's what would be so funny.
Because heart rate is beats per minute,
Per minute.
stroke volume is mils per stroke. beats per minute is the same. So strokes per minute and mils per stroke. So we end up with mils per minute. So cardiac output, just to rewrite what's on the board, is equal to heart rate beats per minute. And remember, beats are, like I just said, are the same thing as stroke. All right. Times stroke volume, which is in mils. And so we get a total of mils per minute. So if the average heart rate is about 70 beats per minute, or 70 ventricular contractions, and with each contraction, I said our average was about 70 mils, then that's going to come out to about 4,900 mils per minute. Or if we round it up, about 5 liters per minute. And that's cardiac output. Right? If cardiac output goes up, what's going to happen to blood pressure?
It's going to go up.
It's going to go up. And if cardiac output goes down, blood pressure is going to go down. So one of the things we're going to look at very briefly, we haven't done our urinary system yet, is the effect on the urinary system on blood pressure. Which is why the kidneys, we talked about the arterial portal system briefly in the kidneys. That's why they need to help regulate blood pressure, because their whole existence depends on adequate blood pressure for filtration. So if someone has too high a blood pressure or has congestive heart failure, and within the pulmonary system or the systemic system, blood pressure is so high that it's pushing fluid out of the capillaries and edema is occurring, one of the treatments is to lower blood volume using diuretics or limiting the amount of salt in their diet so that the cardiac output isn't as isn't as high. Now, this is a direct relationship. So if we decrease heart rate, what's going to happen to cardiac output? It's going to go down. If we leave heart rate the same but decrease stroke volume,
It's going to go down.
cardiac output will go down. And so these are linked together, and the body tries to maintain homeostasis, to maintain a normal, adequate functioning blood pressure, which is, blood pressure is hydrostatic pressure. It's the force of the fluid against the arterial walls. So if, let's say someone has been in an accident, is cut blood vessels and is hemorrhaging, has lost blood volume, all right, less blood is coming back to the heart, and we're going to look at some of the factors that affect cardiac output. Less blood is coming back to the heart, so with less blood coming into the heart, less blood is going to be pumped out of the heart. So stroke volume is going to decrease. What's going to happen to blood pressure? You feel the pulse. It's going to feel weak, all right? But to help maintain the overall pressure and movement of the blood, the heart responds by increasing heart rate.
Someone's kind of productive in that.
So if we drop the stroke volume to 50 mils, make my math here easy. So if we decrease stroke volume to 50 mils, what do I have to increase my heart rate to maintain a 5 liter per minute cardiac output? 100. So one of the signs in someone who has lost blood is a rapid but weak heart rate. Rapid because each pump is putting out less volume. That's why the pulse is weak, or thready. You may have heard the term thready. The heart is beating more rapidly because it's trying to move the blood through faster, so the same volume is moving through the body. Right? Remember we talked about pericarditis? Well, at least we talked about the pericardium. There are a couple of terms on that page back at the beginning that I didn't discuss with you, pericarditis and cardiac tamponade. Pericarditis is an inflammation of the covering, the lining of the pericardial cavity. It can lead to cardiac tamponade, but other things can cause cardiac tamponade. Itis just means inflammation. So I had a colleague, chair of the English department when I was teaching back east, and take me on page 10. And he liked to pretend he was one of the college guys, even though he was almost 30, which I know at a community college is not uncommon. But at a four-year college, it was pretty uncommon to have anybody over 30 there. They were typically the 17, 18-year-old freshmen. And he would go out there on Friday afternoon and play soccer. In one game, he and an opposing player hit chest to chest, and they both fell back. And the next morning when he woke up, he had chest pain. He's single, and still single for all I know. And his dad had heart problems. So he was thinking, I wonder if I'm having a heart attack. You know, if I get out of bed and do jumping jacks, that'll make my heart feel worse if I'm having a heart attack. So he got out of bed and started doing some exercises, and his heart kept hurting, but his chest kept hurting, but not worse. So I thought, well, I have a two-story house, I'll run up and down the stairs. That's if I'm having a heart attack, that will change things. Still hurt, but not worse. So I said, I live on a hill. I'll go out and run up and down the hill. So finally,
This man deserves a
he
go.
called some friends, and they took him to the emergency room. And what had happened was when he hit chest to chest, it pushed his sternum against his heart and sheared off the simple squamous epithelium lining the pericardial cavity between the parietal and visceral pericardia. And that allowed a lot of fluid to seep into the pericardial space and increase that fluid that was causing the chest pain. So they made a promise the next time he had chest pain to forget trying to prove he was having a heart attack by dying and just go to the hospital, and gave him some antibiotics and kept him overnight for observation. You've heard of Steve Irwin, I'm sure, who had the stingray through the chest. So any opening either into the parietal pericardium that allows fluid in externally, or through into the cardiac wall that allows blood, when the heart contracts, to seep into the pericardial cavity, causes an increase in fluid, and that's the cardiac tamponade that's mentioned on page 10. When I first moved out to Northern California for graduate school, I started working weekends at the hospital. And about a year or so before I had started working there, they had a patient who came in 6 months pregnant with pneumonia, and she just kept getting worse. They started an IV on her, and her heart rate was going up, and her respirations were getting more shallow. And so after a couple days, 18 hours, they did an x-ray, chest x-ray, to check on her pneumonia. And because she hadn't been able to keep any food down, they started a subclavian line, which is a larger needle and a larger tubing into the vein that passes under your clavicle. And what had happened was the needle had been passed through her subclavian vein and through the parietal pericardium, and all the IV fluid was going into her pericardial cavity. So you can imagine that every time the heart contracted, more fluid could fill up that space, and then it couldn't fill up as much. And so each stroke volume was less than the one before. So what would that do to her heart rate?
Increase.
She just kept going up and up, and unfortunately by the time they figured this out, they weren't able to save either her or the baby. And it was, you know, it's unusual to put a subclavian line in. Usually they do it for parenteral, which means supplemental feeding and so on. So it may have been that she wasn't able to keep food down, and they were just doing supplemental alimentation. But that illustrates really well the relationship between heart rate and stroke volume, and how the body tries to maintain the same amount of output. The same thing you can see with athletes, all right, who, because of cardiovascular activity, develop increased number of actin and myosin filaments. So with each contraction of the heart, the stroke volume is going to be greater. With the increased rest, they have a slower heart rate, because if we change stroke volume to 100, then heart rate can drop to 50. With a slower heart rate, more blood has time to flow into the ventricles, and so they stretch out more, but the heart's strong enough to contract. So it's not that we're pumping out 100 out of 135, we're pumping 100 out of 180 mils for overall cardiac ventricular volume. Because they have that longer rest period, so the heart can get more volume and then it pumps harder. So it doesn't have to be as much. Right? So there's that direct relationship between cardiac output and stroke volume. Let's go ahead and stop here for a break. And then when we come back, I'm going to spend about half an hour just going over factors that affect heart rate and stroke volume. These are factors that we've already talked about, all right, for the most part, but I want to put them together in view of regulation of cardiac output. So come back in about 10 minutes.
Is it cardiac temperament?
Cardiac output will go up. So the heart can compensate if we lose stroke volume, the heart rate will increase, all right? But if we're trying to increase or decrease cardiac output, then we can just change one or the other, and we'll see that effect. So regulating heart rate, we have several different factors, but the most common factor is the autonomic nervous system. And as you're already aware, sympathetic nervous system is going to increase heart rate, and parasympathetic nervous system is going to decrease heart rate. So if we look at increasing heart rate, all right, we're looking at sympathetic fibers. And sympathetic comes from what region of the nervous system?
The thoracic.
Thoracic and lumbar.
Yep.
So when we were looking at sympathetic control of reproductive, we were looking at the lumbar region. Okay? Looking at sympathetic control of cardiac, we're looking at the thoracic region, and it's essentially T2 through T5. All right, so the thoracic spinal nerves, T through to T5, their lateral gray horns are going to send parasympathetic preganglionic fibers, sympathetic preganglionic fibers to the heart. These don't have a particular name. All right, they are called cardioaccelerator fibers. So they're not called splanchnic fibers, they're not called greater thoracic or whatever, they're just called cardioaccelerator fibers, or here they're just being called cardiac nerves. What is the nerve that is going to lower heart rate via the parasympathetic?
Vagus.
Vagus. So that one does have a name, all right? And this forms, both of these form a cardiac plexus. So if you look at the models, the Don Jake Saunders model, the white structures, all of these nerve fibers, the white structures that you see, passing over the pulmonary trunk and aorta, are both sympathetic and parasympathetic. They form a cardiac plexus. Coming down the back of the esophagus, this is the rest of vagus going down into the abdominal cavity. All right, so it's following esophagus and innervating that. But here on the surface of the heart, it's difficult to say which is sympathetic and which is parasympathetic. So in this area, it's hard to go in and just say cut the vagus or cut the sympathetic components.
What are the green on that model?
Lymphatics. The lymph nodes and lymphatic vessels carry excess fluid in the tissues back to the cardiovascular system. So one of the things that I've mentioned but I didn't emphasize is that for sympathetic, there are two types of muscle cells that receive sympathetic innervation. As far as heart rate is concerned, it's going to go primarily to the sinoatrial node. If that's not working, we will see an effect on the atrioventricular node. We also will see an effect on stroke volume. Because there are receptors for sympathetic norepinephrine on contractile cells. Of both the atria and the ventricles. So we'll come back and visit this again when we talk about stroke volume regulation. For parasympathetic, it has receptors also, primarily on the sinoatrial node. To a lesser extent on the AV node. But the only receptors it has on contractile cells are inconsequential. They are on the atrial cells. There are no receptors for acetylcholine on ventricular cells. So atria only. So if we're increasing the force of ventricular contraction or decreasing the force of ventricular contraction, we're doing that only through the sympathetic nervous system. So acetylcholine affects heart rate. It can't make the heart beat stronger or more slowly, more strongly or more weakly by affecting contractile muscles. It can via a different pathway, but indirectly. So what kinds of stimuli would cause the sympathetic fibers here? This says T1, but there's very little sympathetic actually in T1. To come to, if you'll notice, sympathetic goes to the SA node, the AV node, and to contractile fibers of the ventricles, whereas parasympathetic just goes to SA node and AV node, and to some extent, a little bit of the atria. So anything that increases the need for oxygen is going to increase cardiac output either by heart rate or force of contraction or both. If the kidneys need a greater filtration rate, there are hormones and neural reflexes that will increase blood pressure via increasing cardiac output. Okay. So there's heat. Let's say that you're hot and you're exercising, then you're going to have blood vessels dilate in the surface of your skin, and your heart rate is going to go up to move more blood to the surface for heat exchange. If you're exercising and your skeletal muscles need more oxygen, by taking out more oxygen, the blood coming back to the lungs, you're going to have less oxygen, and that's going to send a reflex that will increase sympathetic. So that will drive a higher heart rate and a greater force of contraction. So if we're looking at sympathetic, typically heart rate and greater force of contraction go hand in hand. Because when these nerves fire to increase heart rate, nerves going to the ventricles are going to release norepinephrine to increase force of contraction. Okay, so those typically occur together. Now, do you remember how sympathetic nervous system increase the firing of the pacemaker potential? Norepinephrine or epinephrine from the adrenal gland binds to a beta-1 receptor. If this is on the sinoatrial node or the atrioventricular node, it's going to activate adenylate cyclase, which increases cyclic AMP. And cyclic AMP itself, here it has it doing it by protein kinase, but cyclic AMP itself will open the funny channels, allowing sodium to come in at a faster rate. The potassium is leaving even normally. And the protein kinase will open the transient calcium channels. Do you remember when the transient calcium channels opened? Just prior to an action potential. So we had our repolarization. So here's where we have the funny channels. And here we have the transient calcium channels. And these would be the long-lasting calcium channels that open for our action potential. All right? So as the potassium voltage-gated channels are closing and they reach hyperpolarization, our funny channels open and allow sodium in. We also have leak sodium that's allowing more sodium in than potassium is leaving. And so what happens with norepinephrine, if you remember, is more funny channels open, and they open at a lower, at a higher hyperpolarization. They don't have to get quite as negative inside the cell for that to happen. And then we see our transient calcium channels open as well. So that means that if I do this by dotted line, we're going to reach the threshold earlier, and therefore have more pacemaker potentials, action potentials reached per minute. That's going to increase heart rate. So the inside of the cell is going to become more positive. It's going to reach the threshold potential for our long-lasting calcium channels, and the action potential spikes at a faster rate. This is what we went over on Thursday when I was talking so fast. All right. So here would be our normal rate. All right, under parasympathetic, funny channels don't open as quickly or as many because there's a decrease in cyclic AMP. All right, so that's the effect here due to the cyclic AMP. So we have a decrease in funny channels, as well as the inside the cell has to become more negative before they do open. The calcium channels, transient calcium channels are delayed in their opening. Plus, there's an increase in potassium channels that open. Actually, the voltage-gated channels here that are closing don't close as rapidly. They stay open longer. So not only are we not allowing positive ions to enter the cell, we're increasing the number of positive ions that leave the cell via potassium. So the effect on that is it takes longer to reach the threshold for the long-lasting calcium channels, and therefore there are fewer periods or action potentials per minute. So we have a decrease in heart rate. Okay, so this is just revisiting what I pushed through on Thursday. But the key element is less time to reach threshold, more time to reach threshold. Increased number of action potentials, which enter the ventricles and result in increased number of QRS waves. Decreased number of action potentials, which means a decreased number of QRS waves, which results in a slower heart rate. So this is direct effect on the SA node, or if the SA node isn't working, the AV node. So what we see in this image right here. Okay? So that's heart rate control. So out of our formula, heart rate times stroke volume affects cardiac output. So if heart rate increases and our stroke volume remains the same, cardiac output is going to go up. If our heart rate decreases and stroke volume remains the same, cardiac output is going to go down. Okay. Now let's look at stroke volume. So this is page 58. So we're looking over here, sympathetic nervous system only. Because a slight increase in the contraction of the atria really isn't going to change the stroke volume of the ventricle significantly. So our major effect is sympathetic, norepinephrine or epinephrine binding to beta-1 receptors on the contractile cells. So can I erase the board? You guys okay with that? All right. volume by increasing or decreasing contractile force.
We have two decreasing.
Is it increase or decrease? There we go. Thank you. Now, there are several other factors affecting stroke volume besides just the sympathetic nervous system. So we're going to look at several of these, all right? Before we get to the sympathetic portion itself, we have contractile force, and that's going to be affected by preload. We'll come back and describe each of these. Preload has nothing to do directly with contractility. Though indirectly it does. So this is where sympathetic is going to come in. And then to some extent, afterload. Okay? I want to go to contractility first, because I have that up on the board. And then we'll come back to preload. So the next page talks about contractility or contraction force. And this has to do with calcium ions. So think back to skeletal muscle. And when we sent an action potential through the sarcolemma and down the transverse tubules, the terminal cisternae on either side of the transverse tubules, if you recall, when we look at it in cross-section, we have the transverse tubule in skeletal muscle, and the terminal cisternae were dilated components of the sarcoplasmic reticulum. You guys remember all that? And in the transverse tubule, we had extracellular fluid. So as a current passed through here, it caused voltage-gated channels to open in our sarcoplasmic reticulum. And what ion did we store in the sarcoplasmic reticulum? Calcium ions. Same thing in cardiac muscle. All right, we have sarcomeres, we have transverse tubules. We don't have as well organized a sarcoplasmic reticulum, but we still have a sarcoplasmic reticulum with calcium ion storage. One of the key differences in our contractile cells, however, is that they also have calcium channels in their plasma membrane. So they have two sources of calcium. There's calcium in the sarcoplasmic reticulum of the contractile cell, and there's calcium outside the cell. More calcium, there's kind of a intracellular reflex, if you will. The calcium that's stored in the sarcoplasmic reticulum is released in response to extracellular calcium coming into the cell. It's kind of like priming the pump. So the more extracellular calcium that comes into the cell, the more intracellular calcium is released. All right, so whatever factors increase that is going to increase internal amounts of calcium. So in that sense, we have an increase in contractile force under the sympathetic nervous system because norepinephrine or epinephrine bind to beta-1 receptors. That's going to activate adenylate cyclase and cyclic AMP and protein kinases and open extracellular calcium channels as well as intracellular calcium channels. In addition, the extracellular calcium is going to open intracellular calcium. So this results in cyclic AMP, phosphorylation and activation of protein kinases. And protein kinases open extracellular calcium channels. By that I mean plasma membrane. The channels aren't extracellular, but the calcium is. And they open intracellular sarcoplasmic reticulum. And the extracellular also opens intracellular. It's kind of a cascade. Now, what does calcium do in our skeletal muscles?
It binds to troponin.
It binds to troponin. Same thing in the cardiac muscle. So the calcium is going to bind to troponin, which separates off of the actin. Tropomyosin moves deeper into its groove, and a binding site on actin for myosin is exposed. So, more calcium ions, more binding sites on actin. Right? So this exposes actin binding sites. For myosin. And we have contraction as a result. The more myosin molecules pull on actin, the greater the force of contraction. Okay. Now, unlike skeletal muscle, remember skeletal muscle, we had an all or none response? So the cell depolarized and the muscle contracted. With cardiac contractile cells, it's a graded response. So we don't normally, it's true for skeletal muscle, if we change the environment, we just don't see that happening very much. But if we add more calcium, a greater contractile response. We add less calcium, a lower contractile response. So each individual cardiac muscle cell can have a different degree that it contracts depending on the amount of calcium that comes in because of autonomic control or drugs. All right. So this increases the contractile force of the ventricles. The more calcium ions are present, the more myosin binds to actin, the stronger the contraction. Okay. Again, if you think back to skeletal muscle, the same effects of calcium on actin and myosin. So now let's go back to preload. Preload and afterload sound kind of vague, but they really refer to factors that you can easily visualize. Preload is in diastolic volume. It's the volume of blood that the heart has to pump, the force it has to, that stretches out the contractile walls, the ventricular walls. Right? So preload is reflected on the stretching of the contractile walls. Afterload is similar, but it has more to do with the aorta than the ventricles. So, can everybody see this right here with stroke volume? You guys have that? So I'll just put an abbreviation reminder for you up here by contractility. This is intracellular calcium ion concentration, affected primarily by sympathetic neurotransmitters. Preload has to do with the stretching of the ventricular wall. And the principle on which this is based is called the Frank-Starling law. And it has to do with the recoil of the contractile muscle, not elastic fibers, all right? Even though the rubber band is elastic. But when I stretch this rubber band out, I stretch it just a little bit, it comes back to its original length or diameter. If I stretch it more, it recoils more, but still back to its original diameter, okay? The more I stretch it, the greater the force with which it comes back to its original shape. That's the principle that preload is. The more we stretch out the ventricular chamber, separating actin and myosin filaments as they overlap each other up to a point, because if we overstretch them, obviously there's nothing to grab onto. But as we stretch the ventricular muscle wall with a greater ventricular filling, the greater the force with which the ventricle will contract to force the blood out. So it's indirectly contractile force, all right, but it's just overcoming that stretch. So Frank Starling's law, poor Frank got his name left off, it gets left off a lot, but it's the same thing. So this has to do with venous return. Now that's another term we haven't talked about yet, but it should make common sense, because that's what is occurring during ventricular filling. It's venous blood from the superior vena cava or the inferior vena cava or the coronary sinus that's carrying blood back to the, or the pulmonary veins for that matter, back to the right ventricle and the left ventricle. And during ventricular filling, as the AV valves are open, the walls are getting stretched. That's why we didn't see a huge increase in pressure in the ventricles. So that's being shown here. All right? The greater the stretch of the wall, the greater the recoil and the return of the ventricular muscle. Now, with disease, that doesn't happen. And that cardiac muscle gets thin and flabby and may only partially return, and we start moving into congestive heart failure, because blood's coming back and it's not being moved out at the same rate. So these are just factors that affect venous return and increase it. So why would a slow heart rate increase venous return?
Allows more time for the blood to flow.
Exactly. More time for the blood to flow, so we have a greater end-diastolic volume. Therefore, there's a greater stretch and a greater contraction of the ventricular muscles in response. This is why I said that parasympathetic indirectly can affect stroke volume. Because as the parasympathetic, without any other factors involved, decreases heart rate, that's fewer periods of contraction per minute. What are we doing to the rest period in between the T wave and the P wave? That's increasing. And as we increase that diastole, that period of rest, what are we doing to venous return? It's increasing. So the volume increases. So according to Frank Starling law, ventricle will contract more to push that greater volume out. So it's not directly affecting the force by the calcium ions, it's affecting it via the Frank Starling law. Okay? Exercise. Why would exercise increase venous return?
More muscle?
We haven't talked about the blood vessels, but the large muscles of the lower extremities are sometimes called the second pump. Because what happens to the muscle when it contracts? It gets shorter and bigger in diameter. Our deep veins are covered by these large muscles, and they're squeezed. And that, if you have a toothpaste tube, and you squeeze it because it's closed at one end, what's going to happen to the direction of toothpaste? It's going to go out the other end. If one end is open. So valves, as we'll talk about, keep the blood from going both directions. So as you exercise, you are increasing the skeletal muscle contraction and increasing venous return. So that's going to increase the blood flow coming into the heart. And intrathoracic pressure, as that drops, makes it easier for blood to flow into the heart because there's lower pressure around the heart itself. So this diagram, and you have this on the lower bottom of the page. So this is what I talked about earlier, which is standard. 135 mils in each ventricle. Stroke volume is 70, so our end systolic volume is 65. All right? Now, if we use the sympathetic system only and increase stroke volume, greater contractility, we have an end systolic volume of 35. This gives us a bit of reserve. If we almost emptied the chamber every time and then you had to run, so you got that venous return going because of exercise, you're not going to have much left to be able to compensate for that increased need in stroke volume. So this gives a bit of a buffer, all right? Now with increased venous return, we have a ventricular volume of 175 mils. That increases the stretching of our ventricles, and they contract more strongly. So we're probably seeing both the Frank Starling and the sympathetic effect there. Okay. So that's the preload component. Those are the two major factors affecting stroke volume. All right, heart rate, the sympathetic heart rate, the preload and contractility. So let me put a brief definition up here. Afterload is usually not quite as effective or a major factor. Afterload is more in a diseased individual. So it's the resistance that the ventricles face when they start to pump. All right, so if there's high blood pressure, if someone has high blood pressure in the aorta, the ventricles have to overcome that to open up the semilunar valves. So if there's an increase in afterload, then there's going to be a decrease in the stroke volume because more of it's going to be left behind. So it's kind of that work that you have to do to get, so if you've got a rock, a huge boulder that you're trying to move, if it's round, it's going to be, and it's on an oil, a smooth surface, it's going to be easy without resistance to move it along. If it's half buried in the ground, you're going to have to put a lot of force to get it going before it starts rolling along, okay? So the afterload is that initial force that the ventricles have to overcome to get the semilunar valves to open and the blood that's in the aorta out of the way. So again, that's usually not a factor unless someone is hypertensive or has, narrow blood vessels, which would also cause hypertensive. Now I'm going to stop on the next page. We'll talk about ions when we talk about blood pressure effects. That there's a chart like this on page 62. You will have a table similar to this with some different factors on your exam, in which I will give you a list of events, and I will ask, does it increase or decrease SA node firing? Does it increase or decrease venous return? Does it increase or decrease whatever? Okay. In fact, you should have this one in your files. Last year, we'll see how it goes this semester. I had an extra day. No matter how many years I've been teaching, I always seem to come up with something to do that takes another 4 or 5 hours to prep. My husband thinks I'm the most ineffective teacher because I always am redoing things. And look in here. We're going to go over these questions before the exam. Here we go. Okay, so which of these would function to increase venous return? Exercise would. Well, let's look at the one at a time. Ventricular fibrillation.
No.
No. Why not? blood pressure is going to be dropping to zero because there is no ventricular ejection when the ventricles are just quivering. All right, we're not creating any increase in ventricular pressure. So that's definitely not going to do. Exercise will, because of what we just talked about, increasing the return primarily from the lower extremities. Atrial natriuretic hormone release. Do you remember we saw this briefly when we were talking about the endocrine system? You can kind of figure out atria refers to atria. Natriuretic refers to what ion? Sodium. Na is sodium. That's a hormone released by the heart. Remember I said long time ago, the heart's an endocrine organ? So when the atrial walls are stretched, they release this hormone, which binds to cells in the kidney and increases sodium excretion by the kidneys. So if we get rid of sodium, are we going to retain water or get rid of water? Get rid of water. Remember my little saying I mentioned briefly a while ago? Mary is sodium and water is her little lamb. Wherever Mary goes, her lamb is sure to follow. Wherever sodium goes, water follows after it. So if we're getting rid of sodium and we're getting rid of water, what's going to happen to venous return? It's going to decrease. Okay? Because there's too much venous return is what's stretching the atria. So that's why the hormone is released, is to decrease venous return. Increase cardiac output. Yes, because what goes out has to come back again. So that would increase venous return. Aldosterone. Does anybody know what aldosterone does? We mentioned it off and on, but we haven't been tested on it. Aldosterone is a hormone released by the adrenal glands. It does the opposite of atrial natriuretic hormone. It increases sodium reabsorption. Okay, so with increased sodium reabsorption, what's going to happen to water? We're going to increase water because it's going to follow the sodium instead of out the urine back into the blood. So as water goes back into the blood in the kidneys, we're going to increase venous return because we're increasing overall blood volume. So that's the opposite of a diuretic. Diuretics like Lasix, furosemide is the generic name. Diuretics work under various conditions, but all of them cause the kidneys to increase urine output. Diuretics is a treatment for congestive heart failure. Too much volume, so increased urine formation will decrease in diastolic return. And the Valsalva maneuver. Do you know what that is? That's what you would do if you were to try to blow up a balloon. Basically, close your nose and don't breathe out, and try to breathe out.
I pop my ears.
What happens to intrathoracic pressure?
Increases.
It increases. If I'm increasing intrathoracic pressure, what am I doing to the superior vena cava and inferior vena cava? I'm squeezing them so blood can't flow back in. All right? So Valsalva maneuver is going to, at that particular time, decrease return of blood. It also increases the pressure within the heart, which makes it more difficult for blood to come back because intraventricular pressure is going up.
Is that what the free divers do?
No.
Or is it
Now they're doing something to increase their, maximize their oxygen.
okay, yeah.
Okay? All right, which of the following happens at the end of isovolumetric relaxation? So where are we in the cardiac cycle? So what valves are closed or open? So during isovolumetric relaxation, they're all closed. Okay? So then at the end of isovolumetric relaxation,
Ventricular filling.
so beginning of ventricular filling, the aortic valve is already closed. Ventricular pressure is now lower than aortic pressure. It's falling the entire time. Okay? And then at the end of isovolatile mental reaction, it's also going to be lower than atrial pressure. Okay? So the class periods before our next exam, I have a whole bunch of these slides that we'll go through together. All sorts of things from heart anatomy to pacemaker potentials and blood pressure and so on. Blood vessel pathways. So we'll go through these. So let's stop here. We're done with lecture. And I should have the lecture notes for the blood vessels that we start. We have a little bit more to cover. Summarizing this up on Thursday. We look at some cardiac defects. But I want to stop here with this so we can do lab time. And you guys have a physio-ex, so some of that's going to be out of lab time, so I don't want to take up all of that with just lecture. Give you some credit for that. Let me go check and see if the lecture notes are in for the arteries. We have the first, that's the second part. There's no new lab packet, but there are the blood vessels. And then we'll get started with the lab. A couple of things that we're going to be doing today. Starting on ECGs. So we have some quick and dirty ECG machines. By quick and dirty, they're not really dirty, but they're just a standard 3-lead, not a 12-lead. And they're not using the computer, so easy on, easy off. The PhysioX, all of you in here have not used a PhysioX activity. Okay. The PhysioX you can have access to either in a lab manual book, the PhysioX 8.0 or 9.0, or if you have online access to My AMP, or a friend who has My AMP, you can do it via that. It's either a DVD or online. The directions are online as well as in the book if you have a lab manual. If you want to have your own, it's $40 standalone. Or you can take a friend to dinner or lunch or whatever and borrow theirs. You do not need to fill out the answers inside the PhysioX. All the questions I want you to answer are in your lab manual. Okay? So for the lab answers that you turn in, I want you to attach a strip of your ECG to that, and we'll talk about how to read it and so on. But the rest of the information is based on primarily the PhysioX. The questions, I believe, are the same between 8.0 or 9.0. You don't have to do both. So I just have the lab activities to do if you have an 8.0 book versus the more recent 9.0 book. Usually the questions are different, but I believe for this exercise they're the same, so there's not two separate components. So it's just either one or the other. So take a break. I'll go check on the lecture notes. Then I'll get the ECG machine set up, and then I'll get the fog material going. Okay?
See you, Joe.
It's gonna be epic.
What?
I'm never gonna stop.